Hello guys and welcome back to my channel. So today's video is about the investigation methods in the KROK exam. So we will see what are the mistakes which we are making. We will see what are the highlighting factors which we have to remember in the question. So let's start with the first content. So let's start with the first patient. The first patient states an unstable angina. He was given anticoagulant, nitrates, and alpha adrenoblockers. So however, on the third day, the treatment pain still remains. So we have given anticoagulants to the patient so that his clot can get resolved or dissolve. But on the third day, the pain still remains. So now what we have to do is we want to inject. We will do coronarography, which is injecting a contrast in the coronary arteries to check if there is any clot still persist over there, or let's say wherever is the blockage inside the coronary artery. Next is a case of transient ischemic attack. So transient ischemic attack is also the case of the clot gets stuck in the brain. So due to which the person will have the neuro symptoms as well as some body paralysis or a lot of symptoms. Like weakness, one side weakness of the body. I'll highlight later. For the transient ischemic attacks, we will do ultrasound dopplerography in order to check wherever the clot is stuck. Next patient is complaining about the sterility within the 3 years. So the patient is complaining about the sterility or infertility, we can say. So she's having problems with the pregnancy. She had one artificial abortion. Her menstrual function is fine. Her menstrual function is not impaired. Diagnostic method to start the workup. So in order to check the patency of the fallopian tubes, we will go with the hysterosalpingography, in which the contrast is injected in the uterine cavity to check the patency of the fallopian tube, like if there is some defect, if there is any kind of defect or any other kind of problem is there. So mark hysterosalpingography for that. Next is the patient, the worker. You can read the whole question, but in the end the doctor suspect the asbestosis. So for the asbestosis, we need to go with the thorax X-ray. So the X-ray in KROK question, they also say row entography, which is also known as X-ray. Most of the time in the cases of lungs questions, the choice of treatment will be X-ray, but however in the case of bronchiectasis there is a different treatment. I'll highlight later. So let's go next. Next is a 37-year-old woman having squeezing substernal pain on the physical exertion. Arterial pressure is a bit elevated. Heart rate is 72, or pulse rate. Heart borders are dilated on the left sides and aortic systolic murmur. ECG shows signs of the left ventricular hypertrophy. So if we see the signs of left ventricular hypertrophy on the ECG, so we want to confirm it. So the choice of investigation method was not ECG here. We want to see the structure finally. When we see the structure and the ventricular hypertrophy, then we are going to be sure about the hypertrophy. So for that we are going to do echocardiography. Just consider echocardiography as similar to ultrasound, or it's ultrasound itself. So by the means of ultrasound investigations, we are able to visualize the structure of the hearts very well. So we'll come to know about the ventricular hypertrophy. So we are going to use this echocardiography a lot in the ahead questions as well. Let's go next. So next is a patient, 43-year-old, had cholecystectomy 6 years ago due to chronic calculus. So he had some kidney stones. He had some gallstones before, and for which he had surgery. So lately he has been suffering from the pain in the right subcostal area and recurrent jaundice. During the last 2 weeks, the jaundice hasn't gone, and the papillitis is 0.5 centimeter. So if the question says about the papillitis, which is 0.5 centimeter, in the length has been revealed the treatment. So if the papillae are there, so simply we have to perform the another surgery this time. So we have to perform the endoscopic papillosphincterectomy. So what we do is, along with the papillae, we will remove the sphincter as well. This time they are talking about the sphincter of Oddi, or that ampulla of water, water or water, something like that. So they are talking about that thing. So the papillae along with this sphincter, this time we will resect both of them. So we will do endoscopic procedure. This surgery is easy, so we will perform it endoscopically. Let's go to the next patient. So question number 7. Next patient is complains about the chest symptoms after the case of DVT. So you can watch my video over the pulmonary embolism. I have explained everything there in the very well. So the investigation method for the pulmonary embolism will be selective angioneurography. What we do in this method is we will put the contrast inside the lung arteries, and we will come to know wherever the clot got stuck, which came from the DVT via the inferior vena cava to the cardio system, and then hence to the pulmo system. So let's go next. Next patient complains about the pain in the knee and ankle joints. He has fever. He had a respiratory disease 1 week ago. He has fever, swollen knee and ankle joints. Pulse is high, rhythmic. Arterial pressure is severely low. Heart borders are without change. Sounds are weakened. Soft systolic apical murmur. What indicator is connected with the possible etiology of the process? So I haven't discussed about an acute rheumatic fever yet, but let's discuss the short thing about it here. So pain in the knee and ankle joint is typical for the acute rheumatic fever. The soft systolic apical murmur is typical for the acute rheumatic fever, and the upper respiratory disease 1.5 week ago. So what happens is the person have tonsillitis first of all, and then if the bacterial infection still persists, so at the later stages it will start to destruct the mitral valve later on the later stages. So this is something which we know as the acute rheumatic fever. So the main etiological agent here is Streptococcus pyogenes. So in the cases of acute rheumatic fever, the most important etiogenic agent is Streptococcus pyogenes. So the body will try to fight with that, and in order to remove the bacteria from the body, the body will, or the system will generate the antibodies against the streptococcus agent. So against the streptococcus toxins, we have antibodies in our blood which are anti-streptolysin O. Let's go to the next patient. Next patient says that he's an elderly patient. He is having squeezing pain attacks in the substernal area, which irradiates to the left hand, has about 1 year. Examination shows that heart borders are dilated to the left side, and sounds are muffled. Pulse is 76. Arterial pressure is 155/80, which is difficult ranges. ECG shows the left type. The rest of the signs are normal. Additional examination. So the question says he is having substernal pain attacks which irradiates to the left hand. So we suspect some of the occlusion here, the stable angina here. So what we are going to do as an additional method is, since the ECG shows the left type, the rest of the signs are normal. So we didn't really come to know about the pathology. So what we will do with the patient this time is, we will give physical exertion to the patient. So most probably maybe at this time the ECG shows the normal signs, but for example, when we will give physical exertion to the patient, so we will ask the patient to go for ride on the bicycle, and we will connect the electrodes to him and check the ECG again. So remember that the KROK questions also say velo ergometry. So sometimes instead of bicycle ergometry, they say velo ergometry. So go with that option. Next patient states that a pregnant woman in her 8th week admitted to the hospital for artificial abortion. During the dilation of the cervical canal of the uterus by the means of Hager's dilator number 8, the doctor suspected uterus perforation. So immediate tech is to confirm the diagnosis. The good treatment, or let's say the good method to confirm the diagnosis could be laparoscopy or something like that. But the question is incorrect. So but we have to remember it. So when the doctor suspect uterus perforation, what they do is they will insert the uterine probe, which will be having a camera. After inserting it inside, it will show the uterus perforation very well. However, the question is incorrect, but let's make some sense over it. So next let's go to the next patient. Next patient is 46-year-old. Skin is sweaty, especially at night. Having fever. Objectively, chest has marks of scratching. Suprapubic lymph nodes are big, like a pigeon egg. Nice. They are not matted together with the test. So what we are going to do is, the pigeon egg size is really huge. So the lymph nodes are really visible from the physical appearance of the patient itself. He is sweating, especially at night, having fever. So some kind of infection or either tumor he is having. What we are going to do is punction of the enlarged lymph node. We are going to take the fine needle biopsy through it. So we'll make an incision and take the biopsy through the lymph node of the enlarged lymph node, and let's detect the cells from that lymph node. If those cells are malignant cells, or if it indicates the infection, we'll come to know about the diagnosis after doing the punction of the enlarged lymph node biopsy. So let's go to the next patient. Next patient is 34-year-old patient living in the endemic echinococcus region. So when the echinococcus liver affection is suspected, I'll tell you what happens is, echinococcus makes some cyst. There is a cystic stage of echinococcus in the liver. We can see some cysts, which are also known as alveoli. The cyst which we will see in the liver, we can easily see those cysts through the ultrasound imaging investigations. I think there are more questions over it, in which the examiner want to hear the ultrasound investigation as well. And most of the time, in the cases of like the right subcostal area problems, for example, the gallbladder problem, the bile duct problem, or for example the liver problem, most of the time we are going to use this investigation, ultrasound imaging. So remember, for each echinococcus infection, we are going to use the ultrasound investigation. So let's go next. Next is severe high pressure. Remember from the last video that this much high pressure can be given by pheochromocytoma. So here is the similar question. If you have watched my last video, it's good, you would remember everything. If you haven't watched, please watch the video over the tumors. It is really important. And let's see the question. So arterial pressure is 240 by 120, which is severely high. Mass burdening upon the upper lobe of the right kidney, presuming it belong to the adrenal gland. So they are assuming that it might belong to the adrenal gland. So what lab test we are going to do for that? So if we suspect that tumor of adrenal gland, which is a pheochromocytoma, so we need to estimate the catecholamines, or this and this with the lab test. So catecholamines is the main, which we have by remembering the catecholamines itself, we can solve the question. This question was there in the tumor portion as well. So the question was like, the pheochromocytoma is suspected. So what are the changes in the blood are expected? So expected changes in the blood were increased concentration or increased levels of catecholamine concentration. Let's go to the next patient. So the next patient is a 63-year-old woman. What she say is loss of appetite, aversion to meat, and 2 days ago she had a stomach bleeding. So she has fever, breathing rate is just fine, pulse is okay, arterial pressure is a bit low. On palpation in the epigastrium, the pain and muscle tension. So the thing is that why we have to mark the cytologic? We could have marked the better option as well, but the thing have to remember in this question is aversion to meat. Now at this time, the biopsy or let's say the tissue studies will not be helpful. This time we have to go with the cytologic studies, which are the studies of the cell. So we can remember this question like this, that this time the woman got aversion to meat, that she don't even want to hear the word meat. So if this much problem persists, so we have to go with the cellular studies, which are cytologic studies. So is a 42-year-old woman having micronodular cryptogenic cirrhosis. So due to this cirrhosis, what happens is she is unable to metabolize. So therefore, there will be the accumulation of the ammonia levels, not just in the brain, but there will be the serum ammonia deposits everywhere in the body. So let's see the question. During the last week, her condition is worsening, and she has consciousness problems. So we got our point. So we can suspect that the ammonia got deposited in the brain, and that's why she is having some loss of consciousness. So we need to estimate the serum ammonia. We need to check for the examination here will be the test for the serum ammonia. If the ammonia levels are deposited too much in the body, then we have to correct this micronodular cryptogenic cirrhosis. Let's see the next patient. The next patient is 51-year-old, dull pain in the right subcostal area, epigastric area, nausea, appetite decline during 6 months. History of the gastric peptic ulcer, weight loss. So peptic ulcer plus weight loss highlights something malignancy or cancer or tumor or something like that. Diffuse tenderness and resistance to muscle on palpation. There is a head lymphatic node 1 into 1 centimeter over the left clavicular. What should be the investigation? So we all know that gastric peptic ulcer and weight loss, if this much things are there in the question, so we will go with the esophagogastroduodenoscopy with biopsy in order to rule out the cancer. Let's go with the next patient. So a pregnant woman, it's the 12th week of pregnancy going on. So 12th week of pregnancy, doesn't know if she has ever been infected with rubella. So what are the tactics? So we will so the patient doesn't know if she has ever affected with rubella before, or because rubella is literally rubella or any other kind of torch infections are very dangerous for the baby. So in rubella, if the mother is having rubella, we have to terminate the pregnancy most of the time. And if we don't, then we will see congenital rubella syndrome in the baby, which will be like cataract in the eyes, deafness, and many more defects like that. So let's see what the answer is. So the tactics will be monitoring of specific IgG and IgM. IgM will indicate the recent infection. If there is any recent infection in the body, IgG are against the rubella. So monitoring of specific IgG and IgM with the ELISA. So ELISA test will be enough to diagnose the rubella. So we will check it. And if the rubella is diagnosed, then unfortunately we have to terminate the pregnancy. So question number 18. Next patient is 31-year-old. So the diagnosis, I have made the separate video over rheumatoid arthritis. You can read this question. The diagnosis here is rheumatoid arthritis. So it asks about the X-ray changes. I have even made a short over the X-ray changes of this. So the constriction of joint space plus ulcerations, which are erosions. I have you can see the short and the short in my shorts section of YouTube, and there will be, I have shown the picture of ulcerations or erosions in the rheumatoid arthritis. Next patient states 21-year-old man monitoring pain in the back for last 3 months. Let's go to the examination directly. Reduced mobility in the lumbar spine, increased of muscle tonus in the lumbar area, and such during moving. So these are the findings related to the ankylosing spondylitis. And let's see the X-ray examination for the better things. So pattern of spine revealed bilateral sclerotic changes in the sacrolumbar part. So when there are bilateral destruction or sclerotic changes in the sacrolumbar part, so we are going with the ankylosing spondylitis, which is the problem with the gene HLA-B27, the antigen test. Let's go to the next patient. Next patient is 20-year-old man having a stab knife close to nipple, got a stab injury close to the nipple. Arterial pressure is severely low, pulse is elevated, breathing rate is high. During inspiration, increase of the pulse wave in the region of the jugular vein. So a decrease of the peripheral arterial pressure, a reduction in the arterial pressure, respiratory murmurs unchanged. X-ray pattern of the thorax organs has no peculiarities. After the introduction of 2 liters of the isotonic solution, the arterial pressure still stayed low and the CVP raised to 32. of the water column. First step for the further treatment. So we suspect cardiac tamponade here. I'll try to show some photo in the shorts about this, so that we remember the cardiac tamponade. So a cardiac tamponade is simply the distension of the jugular veins, and even after the introduction of 2 liter of the isotonic fluid, the CVP still kept on raised up to this much. So what we have to do is echocardiogram. So the heart is not pumping effectively, so we are going to do a echocardiogram, so that we come to know that how much if there is any fluid buildup near the pericardium. So this is the feature of cardiac tamponade, that the fluid will get built up in the pericardial sac, and due to which we will see the jugular venous distension, and the heart couldn't pump perfectly because there is a fluid buildup, and which is constricting the pupils. The ventricles are unable to fill properly, the ventricles are unable to relax properly. So this is cardiac tamponade. I'll try to highlight the triad or of cardiac tamponade very well, or maybe I have included in the first video, I don't remember. If not, I'll try to include it. Let's go next to the Sheehan syndrome. So Sheehan syndrome is the basically let's define it a bit. So it's the severe blood loss after the pregnancy, which will lead to the decreased blood flow of the pituitary, and the anterior pituitary damage, hence the pituitary necrosis. So what happens is, during the pregnancycal involution, while delivery or during abortion or during C-section, any of these pathologies, when they are these pathologies are there, so sometimes there is a severe blood loss in the patient. When there is a severe blood loss in the patient, there is decreased blood flow to the pituitary gland, so which will lead to the necrosis of the pituitary gland. So we are going to see the problem with the pituitary glands or the hormones whichever the pituitary is releasing. So let's get to the question. The question says that a 24-year-old patient is 13 months after the first labor, consulted the doctor about the amenorrhea. So amenorrhea is the problem with the menstrual cycle. So menstrual cycle is really controlled by the pituitary hormones. If the pituitary hormones will not be there, then we will have problem with the menstrual cycle. So pregnancy has concluded by a cesarean section concerning for the premature detachment of the normally positioned placenta. Hemorrhage has made. So the loss, the next line highlights the 200 ml of the blood loss was there. So you know that when there is this much blood loss, this is the risk factor for the Sheehan syndrome. And we are going to use this investigation method in more questions over there, because a lot of questions are there I have seen in the test center about the Sheehan syndrome. So there will be the we are going to do the determination of gonadotropins. So gonadotropins are released by the pituitary gland. So if we will check the gonadotropins, we will come to know if the pituitary is working properly, or if the pituitary response is negative. So if the pituitary response is negative, it means during the last blood loss the pituitary got necrotized, and this is Sheehan syndrome now. Let's go next. Let's see the next patient. Next patient is 34-year-old woman having the 10th week of gestation. Consulted the doctor of the antenatal clinic on the purpose of the statement of the dispensary record in the previous pregnancy that took place hydramnion. And the child birth weight was 4086 gram, which is higher than the norms. Normal could be 3.5 or a little bit higher. So method of examination to carrying out the first of all. So I have highlighted it here, hydramnion, which is excess amniotic fluid. So excess amniotic fluid is the risk factor for the gestational diabetes. So what we are going to do here is, since we see the child is also having the high weight, so what we are going to do is as a method of examination to carrying out this. So we will test for the glucose tolerance test, so that we will come to know about the glucose level in the patient. Let's go to the next. On the 4th day after injection, 6-year-old patient felt pain and tissue induration in the left buttock. Objectively, the skin on the subexternal quadrant of the left buttock is red hot hyperemic, indicating an abscess. Palpation is painful infiltrate 6x6 with a large softening in its center. So what we are going to do in order to diagnose it. So we can do punction. We see that these are the characters of abscess. First of all, he got an injection, so it's the post injection abscess basically. And buttock is red, hot, hyperemic, so they are rubor, calor, dolor, and a lot more. What we are going to do in this one is action necessary to diagnose abscess is the punction. So we'll come to know about that. And the quickest way to diagnose punction doesn't mean anything else. It simply means the needle biopsy, the quickest way to diagnose. So with the biopsy we'll come to know. Next is 30-year-old patient having a skin itching intensify in the evening. He has been ill for 1.5 months, and the rash with the paired papules covered with the bloody crust on the abdomen, hips, buttocks, folds between the fingers, flexed surface of the hand. There are traces of line scratch. So remember about the scabies disease. So scabies disease, in the scabies disease, the itching is itching on the rashes are all the time. So the scaby pathogen moves inside the upper layer of the skin, so it will create some sort of lines which are highlighted here, line scratch. So the rash will be like line, a dot after dot after dot, like that. It will be like a line, like total rash, dots making a line. And itching will be all the time, but especially once it is evening, the itching will be very severe, and the itching is this much severe that the patient will not be able to sleep overnight until he takes some pill for anti-itching pill. So remember about this, that when we are suspecting scabies, I don't think that this much itching could occur in any another pathology. I have seen it. So this is very severe itching. So what we are going to do is we will do examination of the rash element scarp. We'll take the cell from the rash and we will try to diagnose it. However, there are another methods of diagnosing scabies nowadays. This was old method. There are more easy methods to diagnose scabies nowadays. Let's go to next patient. Next patient is another patient having a right subcostal pain after the fatty meal. So last week attacks have been repeated every day and become more painful. Diagnostic methods. So when there is right subcostal pain, I have told you in the same video that we are going to use ultrasound as an examination method for the gallbladder. Why? Because it is non-invasive. Why? Because it will show the clots and or gallstones or whatever is the pathology very well. So it is non-invasive, fast method, and the choice of treatment for the gallbladder, the bile ducts, and sometimes the liver as well. A lot of things, even the pregnancy as well. So ultrasound examination, mark it. Let's go next. Next is the case of bronchiectasis. This is what we were waiting for, that most of the time in the KROK questions, we are going to see the X-ray pathologies. X-ray is the choice of investigation in most of the lung pathologies. So here is the case of bronchiectasis. 8-year-old, constant pain, green sputum, dyspnea during the physical exertion, at the age of 1 year and 8 months, ill for the first time, bilateral pneumonia. Later on, the recurrences of the disease 5-6 times a year. During remission periods, there was a constant productive cough. So constant productive cough. I hope you know about the bronchiectasis. So there is a lot of sputum is mentioned in the question, and this is enough to diagnose as bronchiectasis. So when we want to go for the diagnosis of choice, so diagnosis of choice will be bronchography. So this is what is I wanted to highlight, that BB. So bronchiectasis, go with the bronchography. Do not mark bronchoscopy, please. It is bronchography. So remember, we can in the option bronchoscopy will be also given, but remember about it, bronchiectasis. You can see, you can compare both of the word, bronch, bronch. So next is ctasis, ctasis graphy, not the scopy. All right. So I hope you will remember. I hope no one will mark at least X-ray for it. Let's go next. Next is they are having the pneumothorax. Next patient is about the pneumothorax, and they want to do the drainage of the pleural cavity. So Nowadays we have more better sites for the drainage of pleural cavity, but remember about the KROK's treatment. In the second intercostal space along the mid clavicular line, we are going to do the pleural puncture. So pleural puncture should be made in the second intercostal space along the mid clavicular line according to the KROK questions. Let's go next. The doctor suspect the abscess of the Douglas pouch. So the best way, Douglas pouch, you remember that it's around the rectum. So in between the bladder and the rectum, somewhere like that. So uterine pouch also we can say. So what we are going to do is, when the abscess of the Douglas pouch is there, the best way or the least invasive procedure will be the digital examination of the rectum, so that we come to know about the Douglas pouch abscess. Let's go to the next patient. Next patient says next patient says, age 49, fever, he is having fever, heart pain, dyspnea, S1 is clapping, S2 is accentuated over the aortic area, opening sharp, the murmur can be detected, most efficient examination for the valvular disorder. So the question, main thing in the question, he say valvular disorder. So there is some failure of the valve or something like that, there is some defect in the valve. So we want to visualize the structure. So when we want to visualize the structure, mark the echocardiography we just discussed. So structural problem, ultrasound, or let's say echocardiography. Also sometimes in the question Doppler echocardiography will be given, so mark it. Next patient is 25-year-old who is having weakness, dizziness, appearance of the hemorrhagic skin rash. She has been suffering from this condition from the 1 month. So let's see the CBC reports. CBC reports: erythrocytes low, hemoglobin low, color index is low, leukocytes are severely low, thrombocytes are low. Diagnostic method. So when all the group of cells are low, so the problem is with the producer, right? Like we can suspect the problem is with the producer, because a producer is bone marrow, and when this much of blood cells are low, so we are suspecting the bone marrow cancer, or let's say some pathology with the bone marrow. So what we are going to do is, we are going to do sternal puncture, or let's say bone marrow aspiration. We will take the biopsy from the bone marrow and we will diagnose what the pathology is exactly. So let's go next. A 39-year-old having hypertension, intense headache suddenly in the region of occiput, recurrent vomiting, presentation lasting for the 5 years. Arterial pressure is severely high. Also in the cases of subarachnoid hemorrhage, we are going to see this much arterial pressure, and in the cases of pheochromocytoma, the pressure will be like even higher than this one. So let's get to the point. Painful of occipital, rigidity of the occipital muscle, Kerning symptom is bilateral positive, subarachnoid hemorrhage is suspected. So we don't know yet if it is a meningeal syndrome or the subarachnoid hemorrhage for sure. However, according to me, this is subarachnoid hemorrhage, not more like meningeal syndrome, because the intense headache occurs in the subarachnoid hemorrhage. Moreover, Kerning signs, they all are positive in meningeal syndrome as well, but the method to confirm will be subarachnoid hemorrhage, since they are also suspecting this, and also the arterial pressure is so high for marking the subarachnoid hemorrhage. It's enough to mark. So diagnostic method in the both of them, whatever you suspect, meningeal or subarachnoid, in the both of them, we are going to see lumbar puncture. We are going to do lumbar puncture. So when we will do the lumbar puncture, if the CSF is bloody, then it means the subarachnoid hemorrhage. So we will be having the choice of diagnostic methods. So let's go next. Next patient is 25-year-old having meningeal syndrome. This time is the patient of meningeal syndrome. So having fever, slight swelling in the neck. His illness is diagnosed with acute respiratory distress syndrome, acute lymphadenitis. Treatment course included erythromycin, hot compress on the neck. In the course of treatment, body temperature rose, headache, repeated vomiting, meningeal syndrome. This is what we wanted to hear from the question. In the end, it is mentioned meningeal syndrome. Studies necessary to find diagnosis. So another puncture, remember about the cerebrospinal puncture or CSF puncture or lumbar puncture. These both are the same thing. So lumbar puncture, CSF puncture, cerebrospinal puncture. So we are going to see some typical changes for the meningeal syndrome in the CSF, not the blood this time. So it will be necessary to make the final diagnosis will be a lumbar puncture. Next patient is a 3-month-old baby having a scrotum growth on the right, elastic consistency, and which increases in the size during crying and decreases in the size during sleep. So examination for diagnosis. So this is the KROK style profile for the congenital inguinal hernia. That the baby is 3-month-old. There is elastic consistency which is increasing when the child cries because of the pressure buildup in the abdomen when the child will cry. So it will elevate, or when the child will be sleeping, so it will get back to its place. So the examination for diagnosis is palpation of the thickened cord crossing the pubical tubercle. So or we can say the sign of silk glove. Sign of silk glove simply means that when two layers are rubbing with each other, something like that. So when two layers are rubbing with each other, it feels elastic consistency, and this is something known as sign of silk glove. So we'll try to palpate the thickened cord or the spermatic cord, whichever we are suspecting that it is thick or it is elevating when the child is crying. So we will try to palpate the thickened cord which will be crossing the pubical tubercle. So we will come to know, or we will come to know about the confirmation of the congenital inguinal hernia. Let's go to the next patient. Next patient is a pregnant woman who is diagnosed with the hepatitis. So hepatitis, let's confirm it. How do we confirm hepatitis? We are going to confirm the hepatitis with the ALT, which is also known as SGOT. Remember it, that not ALT is always given in the as an option. Sometimes they will be SGOT will be given. ALT was not given. I wrote it by myself to understand. This is for hepatitis. We are going to do the liver function test, which is ALT, or also known as SGOT. The full form is here: serum glutamic oxaloacetic transaminases, or let's say alanine transferase. So this is done. Question 36. 26-year-old woman was delivered a child 7 months ago. Nausea, morning vomiting, sleepiness for the last 2 weeks. She suckles the child. Menstruation is absent. So she hasn't applied any contraceptive diagnostic method. So a very bad English with this question. The translation errors are a lot, that we cannot understand what the pathology is there. But I somehow made the concept. I understood it, that if the menstruation is absent, the question want to highlight that she is pregnant again, and for that because she hasn't applied any contraceptives, so the question is tricky, or let's say a bit incorrect. So she hasn't applied any contraceptives, which will, and she is having the age 26, so she would have had sex before. So without contraceptives, menstruation is absent, indicating pregnancy. The diagnostic method for pregnancy, ultrasound. Let's go next. So next patient is a 10-year-old girl, abdominal pain, getting worse after each rough and spicy food. She complains about this sore eructation, heartburn, frequent constipation, headache, irritability. She has been suffering from this for 12 months. The girl diet is inadequate. Sorry. The tongue is moist and with the white deposit at the root. Abdomen is soft and painful in the epigastric part. So pain in the epigastric part when we suspect all of these things. So if she is eating spicy food, the pain is getting worse because probably she is having the symptoms of GERD. So her she's having some sort of vasodilation in that lower sphincter of the esophagus, due to which whenever she is eating spicy food, which will cause the intensive release of the HCl from the stomach, and when the HCl is releasing too much after the spicy food in the stomach, so it will cause the acid reflux. So when acid will get reflected to the esophagus, it will cause the symptoms like heartburn. Trust me, the pain is so severe in the heartburn. I have noticed it. Next patient is 38. Question 38. After delivery and the revision of the placenta, there was found a defect in the placental lobule. General condition of the patient is normal. Uterus is firm, moderate bloody discharge. Speculum inspection of the birth canal shows the absence of the lacerations and ruptures. Action necessary. So they found some defect in the placental lobule. So they need to revise the whole cavity now. If there is any defect left in the uterine cavity, or if there is any abnormal thing left in the uterine cavity. For example, let's say when the defect was found in the placental lobule, the baby is delivered, the placenta is attached to the baby. Now they are going to cut it. Now they notice that there is some defect over there. So the leftover part from the placenta has left inside the uterine cavity of the mother, probably, right? So if that part will still stay in the uterine cavity of the mother, it will cause a lot of infections. So we will have to manually revise the uterine cavity or remove that part manually. So let's go next. Next patient is the case of phenylketonuria. 4 month. Remember about this question itself. So a 4-month old girl with the blonde hair and blue eyes, having mousy odor of the sweat and urine, and development and delayed development, and most typical laboratory data. So we want to diagnose the phenylketonuria, mousy odor and the sweat, mousy odor of sweat and urine. We already suspect phenylketonuria about this. So in the cases of phenylketonuria, we have to go for the positive urine ferric chloride test. However, this is very old treatment. Nowadays we are not going to use this treatment, but remember, for the KROK questions, this is the treatment of choice for the cases of phenylketonuria. And another question I have found for you for the phenylketonuria, I cannot make a separate video over phenylketonuria because this is very short topic. So let me tell you about phenylketonuria in this question itself. So phenylketonuria is the genetic disorder which is characterized by the body's inability to metabolize the phenylalanine. So symptoms will be developmental delay, seizures, behavior issues, or musty odor, or let's say mousy odor, and eczema can be there. So there was one more question in the KROK. They have asked that screening detected phenylketonuria in a 2-week old baby. So what will be the treatment? However, the treatment is bullshit. They mark the treatment, they say, is special diet. It doesn't make sense to me. But just remember that according to KROK, the treatment of phenylketonuria is special diet. However, we can make some sense by thinking like that definition, that this is the genetic disorder characterized by the body's inability to metabolize phenylalanine. So maybe if we remove the phenylalanine, or if we remove it from the diet, so it can be the treatment of it. question. 36-year-old female having general weakness, edemata of the face and hands, rigid fatigability during walking, difficult deglutition, cardiac irregularities. Symptoms turned after 11 days of the seaside holidays. So nothing important yet in the question. Face erythema, edema of shin, muscle and hand. So let's see. ALT and AST are given. Aldolase is given. Creatine phosphatase is given. So this is according to me, this is most important finding of the question. When the creatine phosphokinase level are increased, it means there is some sort of muscle damage is there. When there is a damage in the muscle, so the byproduct which forms is creatine phosphokinase. So it is 2.5. I don't know yet what is the normal level. I'll tell you in some another videos, or you can check it on Google right now. So when the question says about creatine phosphokinase, we suspect muscle destruction. Let's see it here, what I have wrote. Neuromuscular disorder, myopathy or muscular dystrophy. Aldolase plus CPK increase, it means muscle damage. So this is what I've told. So we are going to take the muscle biopsy in order to check the muscle destruction. Next patient says, as a result of load lifting, 68-year-old female, acute pain in the lumbar, in the buttock, in the in the post lateral surface in the right thigh, external surface of the right shin, dorsal surface of the root, weakness in the anterior tibial muscle, long extensor muscle of the right toes, short extensor muscle of the right toe, low Achilles reflex on the right. In the Achilles reflex, what the doctor does is he take a hammer, a neurological hammer or neuro hammer. So he will strike the hammer uh, below the patella bone, and when he will strike the hammer below the patella bone, the leg is supposed to react, or the reflex should be present, or the leg is supposed to elevate after, like the auto reflex result. So it says the low HLE's reflex and positive Lissard sign also I have included in the video, in the first video. So what happens is the patient reports the pain on the elevation of leg, so the Lissard sign is positive. This is Lissard sign shows the nerve root irritation or compression. So what examination diagnosis is okay, now the question makes sense. What examination diagnosis of compression of the L5 root? So we want to see the compression of the root L5 in the lumbar area. So we cannot see the nerve compression or the L5 compression in the with the X-ray, right? We need to go with the MRI for that. You know that the in the cases of when we want to check the soft tissues, we will go with the MRI scan. So if we want to know about the compression of the L5 root, we will go with the MRI scan. So next similar question, there is diastolic shock above the pulmonary artery, interval systolic murmur on the cardiac apex. A lot of things are there. Examination, we suspect something is wrong with the structure, so we will do echocardiography. Next question says the 67-year-old having edemata of face and legs, pain in the lumbar and getting worse in the moving, general weakness. It should be general weakness, probably it's wrong. So sometime nasal hemorrhages, he is having fever, objectively painfulness of the vertebral column and rapes on palpation. Daily proteinuria is so severe, like the nephrotic syndrome or glomerulonephritis. Daily proteinuria is 42, ESR is 52, expected lab changes in the so the question is asking about what are the changes expected in the CBC of the patient. So if this much pathologies are given, so I think we have to remember about this question a bit. This question is not really making sense a lot, but this is how I made sense for myself, that the daily proteinuria of the patient is this much, that the whole blood protein in the whole protein in the blood serum has left only 101 gram per liter. So nephrotic, I have wrote here nephrotic syndrome, protein loss in urine. So I have wrote something here as well. Normal serum proteins are 60 to 83. Infection, inflammation, multiple myeloma, production of the gamma globulins, which therefore there will be protein level increase. So just remember the question, guys. When there is daily proteinuria, if this much, so we are going to expect the whole protein blood serum will be 101 gram per liter, or let's say this much left, because the proteinuria is real. So let's go next. Next is 54-year-old female patient having bloody discharge from the genitals after 2 years of the amenorrhea. USI and bimanual examination shows no pathology. So what we are going to do now is, so the patient is having amenorrhea and bloody discharge from the 2 years. So what we are going to do is bloody discharges, which is something abnormal finding. So due to the abnormal finding, we are going to take the fractional biopsy of the lining of the uterus and uterine mucous membranes. Since the patient having menopause already, yeah, she is in the age of menopause, 54-year-old. So after menopause, the chances of ovarian cancer as well as endometriosis increases after menopause. So we are so better to take biopsy for the bloody discharge, because bloody discharge are normal, not normal for this right now. She is having menopause already, so bloody discharge make no sense here. So we want to take the biopsy of the lining of the uterus in order to rule out endometriosis is there, or if there is any another pathology is there. Next question says about liver echinococcus, which you know already about the ultrasound. This is the case of SLE. So I have told you while making the video over the SLE that in SLE it is a it is an autoimmune disorder in which the antibodies will be against the anti-nuclear factor, anti-nuclear DNA or ANA, like that. So let's go to next question. Next question is 54-year-old female, bloody discharge from the vagina for a month, 1 month. Last menstruation was 5 years ago. Gynecological examination revealed no pathology. So since she is having a bloody discharge from vagina and there is no another pathology, so we will go with the option diagnostic fractional curettage of the uterine cavity. It includes the revision of the cavity as well as if there is something which is abnormal causing the bloody defects, so we can remove such defects, or if there is endometrial problem, so we can remove the endometrial layer itself. So diagnostic fractional curettage of the uterine cavity is the choice of treatment here. Next question says about the purulent and profuse discharge. So you can read the question, but the main thing is her history says sexual life out of well-dogs and 2 artificial abortions, purulent and profuse discharge. So what we need to do is for this is, since the discharges are purulent and she is having blah blah history, so due to that we need to check for the bacteria, because due to the purulent discharges are the result of the bacterial infection. So we are going for checking the bacteriological and bacterioscopic analysis. So let's go to the next patient. Next patient is complaining about the patient eaten too much fatty food, resulted in the sudden pain in the right subcostal area. So having bilious, vomiting, strong sensation of the bitterness in the mouth. 2 days later, the patient presented with jaundice, dark urine, sclera and the skin are ecteric, abdomen is swollen, liver is +3, soft and painful palpation. Ortner, Keher, Murphy. So remember about Ortner, Keher, Murphy. They are the signs for some problem with the gallbladder, like the enlargement of the gallbladder, or gallbladder is painful. For example, in Ortner sign, we tried to punch slightly with the open hand on the right subcostal area of the patient and the left subcostal area of the patient. So the patient reports the pain on the right subcostal area. However, the patient doesn't report the pain on the left subcostal area. So if the patient reports the pain on the right subcostal area, this is a positive Ortner sign. So similar are the Keher, Murphy. So they are signs for the gallbladder. So I have told you in the video before. So when we are suspecting something with the gallbladder like this, so we are going to mark the ultrasound investigation of the gallbladder. So let's go next. Next patient is 19-year-old having severe dyspnea, pain in the left chest, sick from 3 days, and objectively he have fever, breathing rate is 42. 42 is very high, severely high. Hypopone means decreased breath depth. The depth of the breath is the deepness of the breath is decreased. So dullness on percussion on the sound on the right, on the scapula middle, breathing sounds can't be auscultated. Left border of the heart displaced outwards, embryocardia, heart rate this, and the right hypochondrium is painful on palpation. So what the question is trying to highlight is the pain in the left chest. So severe dyspnea. So this is the profile of the fluid buildup in the pleural cavity. So when there will be on the left chest, when there will be fluid buildup on the pleural cavity, what happens is the lung will start to get collapsed, and due to fluid buildup, it can be caused by any trauma or something. So due to fluid buildup in the pleural cavity, the pleural cavity will keeps on increasing and the lung will start to keeps on collapsing. So that's why the patient the question says dullness on percussion on the right. So on the right side there is dullness because there is liquid, and breathing sounds can't be auscultated. It's because the lung would have collapsed probably. So there will be no breathing sound because there is too much of the fluid filled in the pleural cavity. Left border of the heart displaced outwards. It's because there is too much fluid filled in the lung. So it is causing some sort of congestion. So when there is some congestion, so the heart is trying to adjust itself or its position by the or trying to save itself from the congestion. So that's why the heart left border of the heart displaced outwards. So treatment, treatment is a main treatment for the liquid buildup in the pleural cavity will be the drainage or urgent puncture of the pleural cavity. Since the patient is having a breathing rate at the level of 42, so 42 marks something like the emergency condition. So when you see the emergency condition of the patient, then mark urgent procedure, urgent puncture of the pleural cavity. Let's go to the next question, 59 question. To study the physical development of the children and adolescents, anthropometric studies were widely used in the physiometric methods of the study. So I hope you are watching my other videos as well. In the other videos I have explained that if the secondary sexual if characters are given in the question, then mark that one, and if that is not given in the option, then mark the vital capacity of the lungs. So if you will watch all of my videos, you will get the concepts, or the concept will start to merge up together. So let's go next. Next is question number 60. Question number 60 highlights that 18-year-old patient having no problem in percussion reveals the heart borders are displaced to the right and left by 1 centimeter. So this is simply the case of dilated cardiomyopathy, that the heart borders are displaced to the right as well and to the left as well, and they are 1 centimeter. So most probably the dilated cardiomyopathy. So coarse systolic murmur with its epicenter in the fourth intercostal space on the left. So we are suspecting the dilated cardiomyopathy. So what we want to do is we want to do the ultrasound examination. So ventriculography, the ultrasound examination, or you can say echocardiography, ventriculography, ultrasound investigation, they all are the similar things or the same things. So I hope this is clear. If not, you can tell me in the comments anytime. Let's go next.